This is Heart Rhythm TV. I'm Roderick Tung. I am joined by the Ilan Goldenberg from University of Rochester, Professor of Medicine, Cardiology, and Director of Cardiovascular Research. Welcome, Ilan.
Welcome. Thank you. Thank you for having me. It's a pleasure.
Well, we're really fortunate to be able to have you. I know that this paper, which is our featured article of the month, was also the talk of the town as well and a discussion point during Heart Rhythm 21. And the paper we're discussing today is really use of oral contraceptives and its implications in patients with long QT syndrome. So
Yes.
I think to just get things started, everyone probably knows that Ilan is a very accomplished researcher and is known for the 2008 Goldenberg U-shaped curve, which really highlights a lot of what you do in your career, which is to identify patients at the lowest risk as well as the highest risk, and understand when you're, too healthy to benefit, too sick to benefit. And this is a great example of yet another risk stratification in which we're trying to understand potentially even mechanisms into why women have long QT intervals. What's our current understanding of these gender disparities and the influence of sex hormones on QT?
This is very interesting. When I started out as a fellow, actually, at a heart research follow-up program with Arthur Moss, we identified initially that boys experience a significant increase in the risk of cardiac events and even life-threatening events during childhood. But there was a significant risk reversal that amazed us, is wherein after the onset of adolescence, boys, the risk of cardiac events and life-threatening events appears to be attenuated, whereas among women, after the onset of adolescence, there appears to be a significant risk increase that is more pronounced during the postpartum period. And we also identified that it's pronounced during the perimenopausal period. So there appears to be a significant interplay between sex hormones and the risk of life-threatening events, arrhythmic events in patients with long QT syndrome.
And this resonates with me because my whole EP career started with measuring QT intervals as a college student at Northwestern with Alan Kadish and Jeff Goldberger, and looking to see what happened after HRT in postmenopausal women. So it's kind of nice full circle for me to learn now from the Rochester group. Tell me a little bit about, for those that are interested in building, genomics or these sort of specialized programs, how do you all of a sudden end up with 1,600 patients with long QT syndrome at Rochester?
So I will give the initial credit to Arthur Moss and the International LQTS Registry. Up until now, to date, we have about almost 10,000 probands and family members of the International LQTS Registry. We have a big LQTS team that is actually has personal connection with all those families. A week ago, we had the LQTS family seminar, which we distributed our data to our patients and got questions from them. So this is a very long-term personal connection ongoing for more than 40 years. When I was here in 2010, we identified those sex differences and we wanted to further study that. So we studied a prospective questionnaire for all women in the registry who are still alive, in which we collected data on menarche and onset, oral contraceptives, type of oral contraceptives, the occurrence of pregnancy, and menopause in this population. And this led to a series of clinical and translational studies looking at the association between sex hormones and the clinical course of LQTS women in this registry, which is a fascinating analysis. And we identified multiple important outcomes that may also translate to drug-induced long QT syndrome, which is a wider problem in the general population.
That's a great way to set this up. Let's dive a little bit, Ilan, into the clinical question, at least in this manuscript, and what the clinical events were and the different groups that you were studying.
Yeah, as a background, we hypothesized something different, and the results appear to have led us in a different direction, because we know from basic science and some measurement that estrogens appears to increase QTc and actually is associated with a reduction in potassium current that may increase the risk of cardiac events in LQTS patients. Progesterone has an opposing effect and may increase potassium current and may be protective, and testosterone as well may be protective. And this possibly may be the risk that boys after the onset of adolescence have a lower risk of cardiac events, and women have an increase in the risk of cardiac events. And this actually came as our hypothesis because oral contraceptives represent a model with a very high concentration of sex hormones, but some of them are a combination of progesterone, testosterone, and even the fourth generation one, the currently administered one, have anti-androgenic effect, which may increase the risk because we're trying to protect women from possible side effect of progesterone. So it's not a pure model. It relates to the proportion of estrogen, progesterone, testosterone, and anti-testosterone effects in those medications.
So you have these three groups and you look at those with progesterone only, then combination, and then estrogen. And you're looking at clinical events, which is really syncope, sudden cardiac arrest, sudden cardiac death. What are the major take-home points here for our Heart Rhythm Society audience?
I believe there are three major take-home points. One of them, we identified that progesterone-only therapy was associated more than a 2.5-fold increase in the risk of cardiac events, as you mentioned, syncope, or cardiac arrest, and sudden cardiac death. We used a recurrent event analysis. We identified this is the increase in the risk of the burden of cardiac events, not only a first event. This is one major finding. The other one, we also wanted to evaluate whether beta blocker therapy, which is the mainstay therapy in long QT syndrome, is protective. And we indeed identified that women who take oral contraceptives, even progestin-only oral contraceptives with beta blockers, they are not at an increase in the risk of cardiac events, whereas those who are not taking beta blockers have a significant increase in the risk of cardiac events. So it appears that taking oral contraceptives with beta blocker therapy is safe. And the third major finding is the fact that all those events were very high and increased and pronounced in women, as we identified in the past, with women of IKR mutations, LQT2 women. And this may also translate, again, as I mentioned, to drug-induced long QT syndrome. And in this subset of patients, the risk of cardiac events with progestin-only oral contraceptive was more than 10-fold. So this is a very high risk group, and possibly in this population, we would advise not to use oral contraceptives.
That's beautiful. And I think it's really important to highlight the fact that this is not what you initially hypothesized or expected to see. One could argue you rejected your null hypothesis, but the point is, that's the whole serendipity of science. And that's what's beautiful, is that these results were not always what you expected. You thought it might just be more estrogen based, but this progesterone is very interesting. And also for our viewers, many will say, well, this is very niche. This is just long QT syndrome, but this has broad implications with regard to what you're discussing, which is drug-induced long QT. And overall, our fundamental physiological and mechanistic understanding of why there are gender differences between women and men. And obviously the protective effects of beta blockers, I think, cannot be overstated. Are there implications overall public health across all OCPs in patients that don't have long QT? Ilan, is this a word for caution, or should we be worried about generalizing too far?
I don't think we can generalize it to the total population, but we know that there are polymorphism associated with the IKR, and there are also a lot of patients who are taking drug-induced, QT prolonging drugs, not only anti-arrhythmic medication that we deal with, and we're studying that, but also anti-anxiety medication when we prolong QTC. So there could be a subset of patients with a combination of polymorphism, not only long QT syndrome, plus taking some medication that will prolong QTC, in which there is a hidden risk of ventricular arrhythmic events. We're actually studying this now during the menstrual cycle, and as part of the American Heart Association grant, and we applied for another NIH grant on the topic to extend those findings to a wider population of drug-induced long QT syndrome. But I would not advise, again, not taking oral contraceptive in the general population unless there's a known mutation.
So much to understand, because the influence of hormones, autonomics on arrhythmogenesis is just, open frontier still. We know there's catamenial PVCs and catamenial, arrhythmia burdens. And I think a lot of this might be better understood, several years or decades from now. Well, Ilan, this has been a real pleasure for me to be able to interact with you. Again, have studied your work and followed it very closely and been inspired by it, and really grateful for the opportunity to interact with you. Congratulations on this wonderful paper.
Thank you. It was a pleasure talking to you.